Health and Wellness Show. I'm Sharon Chong, and today we have two doctors from Sunway Medical Centre, Dr. Jennifer Leong, consultant clinical oncologist, and Dr. Chong Hoong, consultant colorectal surgeon, to help us break the silence on colorectal cancer. Although colorectal cancer is amongst the top most common cancers in the country, most Malaysians actually are diagnosed late because of poor awareness and also lack of participation for screening. Welcome to the show, doctors.
Hi.
Thank you very much for having us here today.
You're most welcome. Dr. Jennifer, maybe I can start off with you. Can you please summarize how prevalent is colorectal cancer in Malaysia, and also share with us what you see in your practice?
So based on the National Cancer Registry, which compiles the data for all cancer statistics in Malaysia, with the latest registry being from data collected from 2012 to 2017. That's the latest we have. So colorectal cancer is ranked the second top most common cancer among Malaysians after breast cancer. So the incidence is about 13%. So colorectal cancer constitutes about 13% of all cancer cases in Malaysia from the year 2012 to 2017. So when you split among the gender, it is the most common cancer in male among the men, and it is the second most common cancer among female after breast cancer. So we are still seeing quite a number of cases that present stage 3 and stage 4. Again, the data showed that most patients present at stage 3 and stage 4, comprising about 60%.
Okay, but why is there so much publicity on breast cancer for women and also maybe prostate cancer for men, but we don't hear much on colorectal cancer?
Dr. Chong, do you have any opinion on that?
Yeah, who would like to answer that?
I think Jennifer answered that.
Good. That's a very good question. We see a lot of awareness going on, a lot of campaign for breast cancer, prostate, but not so much on colon and lung cancer. So I believe that more awareness campaign can be done to actually increase public awareness. But that said, I think the steps to do so has improved over the last decade compared to a decade ago. People are actually more aware and are more conscious about their diet and exercise and what are the contributing factors. And also I think more people are aware of the role of genetic screening. So they are asking this question. So in my clinical practice, I do have family members that actually are concerned about their risk and actually request if they are suitable candidate or they should go for genetic screening.
I see. Okay. Dr. Chong, does it all begin with polyps in the large intestines?
I would say majority, more than 90% actually start from a polyp. Okay. I mean, average, it takes about 10 years for a polyp to grow from a normal polyp to become cancerous. So because of that, I mean, it's important we pick it up early, you know, the polyp before it turns into malignant. So that's why screening is very important in prevention of a colorectal cancer.
So, but generally, I mean, most people would have polyps, right? So, but whether it's malignant or benign, we wouldn't know until we go for screening. So, but normally at which age do we develop polyps? At a later stage of life, or do we also get polyps when we are young?
There are many types of polyps actually. You know, some you know, it can develop at a later life. I mean, we have other types of which can develop. I mean, even in adolescent or childhood. You know, example like juvenile polyps. You see, so you know, we won't know which type of polyp. And I agree with you. We won't know which type of polyp can become malignant. So that's why whenever we see a polyp during screening, we will remove it. You know.
I see. Dr. Jennifer, earlier you mentioned about if it's genetic, right? So, so when should, just say I have a family member who has or is having colorectal cancer, So as a part of the family, a family member, when should I go for the screening?
Again, very, very good question. So actually we have a colorectal clinical practice guideline adapted for Malaysian practice. So it is not only just for healthcare provider, you know, like doctors to have a look. It's actually for public as well to increase their awareness. You can download it in actually the Academy of Medicine website. So in it does mention a very good section about who are in the high risk group. So genetic screening are recommended for high risk group, i.e. if the patient themselves are diagnosed with colorectal cancer, but at a young age. Because again, from the data, we see that most of the cancer, the high risk group is from the age of 50 and above, right up till 75 years old. So a patient who does develop colorectal cancer at a younger age, below 50, are recommended to undergo genetic screening. And for a healthy individual, if they have a strong family history, i.e. more than 2 family first degree relative. First degree relative here would refer to parent or siblings. Yeah. So if you have a first degree relative of more than 2 that have colorectal cancer at any age, then again, the individual who are not affected, like you and I, then we will have to, we are recommended to go for genetic counseling. Or if there is one first degree relative and another second degree relative, meaning aunt or uncle who have colorectal cancer. So more are actually outlined who are at risk. So essentially, if there's a strong family history of malignancy in the family, they could be having some form of, we call it the cancer syndrome, hereditary cancer syndrome, HNPCC, hereditary non-polyposis colorectal cancer. So actually what the geneticist does is they will actually outline, they will map out the family tree and find out where are the risks and then what kind of appropriate genetic screening to be done. And why do we actually recommend early genetic testing? Because then we can outline or assess the risk of the patient, because we know patients who have hereditary cancer syndrome, their chances of developing colorectal cancer increases with age. And they're at higher risk than the usual normal population risk, background risk. So by knowing that they are at high risk, you can then advocate earlier screening. For example, you may start colonoscopy screening at 40 years old and then do it regularly. So that hopefully the aim is to actually detect early, because early detection will lead to earlier treatment and then improve survival outcome.
So Dr. Chong just say if the screenings show there is abnormality, okay, is surgery the only solution or are there other treatments?
Okay, I mean, once if you confirm malignancy, you have a cancer, have a tumor, the first thing we'll do stage the disease. Okay, that's when we will do either a CT scan or a PET scan to determine the stage of the disease. And based on the stage of the disease, only we decide whether is this patient suitable for surgery first. Sometimes there's a role of chemotherapy or radiotherapy before the surgery, which we call the neoadjuvant therapy. So, but of course, surgery will be the mainstay of treatment.
I see. But so can surgery cure colon cancer?
Well, I mean, it depends on the stage of the disease. Of course, if, you know, like Dr. Jennifer said, early stage, if you detect it early, we have a better chance. I mean, of course, you know, you need to go through the proper treatment, you know, whether you need surgery followed by chemotherapy and radiotherapy after the operation. You know, I mean, if follow the more treatment modality, of course, if it is early stage, the chances are usually quite good.
So what is the risk like for colon cancer surgery?
You mean the risk of the surgery itself?
Yes.
Okay, of course, any surgeries will come with a risk, you see. For surgery, usually there are 2 types of risks. One is the anesthetic risk and one is the surgical risk, okay? The anesthetic risk is, of course, you know, the risk to the anesthesia, usually, you know, whether the patient have heart problems or multiple comorbidities like diabetes or hypertension, these are things. Surgical risk, I mean, of course, any surgery on the colon we consider as a major operation. Okay, the most common risk that, you know, we encounter, one is of course bleeding. Okay, any operation that have bleeding. Secondly, have wound infection, after the operation. And thirdly, the most important thing is whenever we resect a colon or the bowel, where we need to join back the segment of colon together, there is always a risk of leak, what we call the anastomotic leak, which can range about 5.
I see.
Yeah.
So after surgery, can the patient live a normal life? Because I would presume that you would have to take out part of the intestines.
Yeah. Of course, they can lead a normal life. I mean, it all depends on the location of the tumor, whether it's a colon or at the rectum. Usually, if the location is at the colon, it won't affect much. I mean, patient will go on with normal life. There is a small percentage of patient where the tumor is at the rectum or near the anus. In this instance, the patient will have a permanent stoma after the operation. So that can alter their lifestyle a bit, but most of them, once they get used to it, they still can lead a normal life.
I see. Dr. Jennifer, earlier you mentioned about, hereditary. Okay, so what about environmental factors? Are there ways to reduce risk of this kind of cancer?
So about 75% of colon cancer are actually sporadic. So
Okay.
environmental factor play a role, and 25% is a familial or hereditary risk. So there's a very, very strong attributes towards the diet, as in processed meat. So there are a lot of trials that has been done, and there's a strong association between having red meat, and processed meat. So
Okay.
the other thing that are very strongly related that can attribute or increase the risk of developing colorectal cancer is obesity. And also lifestyle habits such as smoking and alcohol consumption have actually been shown in studies to have increased risk in such patients. So patients with diabetes also have about 26% risk of developing it if you look at the studies.
I see. Okay. So say if there's no family history. Okay. So if I'm just say I want to go in for a screening, when should I go in for a screening just to be safe?
So we divide
there's
them.
no symptoms unless there's bleeding, I would presume.
Exactly.
Yes.
So if let's say in a well and healthy individual with no symptoms, suspicious symptoms, then again, to simplify it, there are 3 risk groups. So in a very low risk, with no strong family history, so the recommended age to start screening, if you look at the CPG, the clinical practice guideline, is at 50 years old. So what is recommended in the guideline is that minimally at least it's a fecal occult blood test. And if it's normal, then it's yearly. And if it's abnormal or come back as positive, then the individual is advised for further evaluation with a colonoscopy examination.
I see. So if, just say if a patient comes in with bleeding as a symptom, is that a late stage of colorectal disease, or will it lead to malignant, or you wouldn't know?
I think again, we will tie in the symptoms. So usually there are also other telltale signs, but if patient present with bleeding or blood mix in their stool, and also when we get further history, there's such a history, again, we look at the age group. If they're in the age group, okay, there's family history and there is a significant loss of weight, or if someone has an unexplained anemia or low hemoglobin, then we would actually likely to do further investigation on this patient.
Dr. Chong, what are the current treatments besides surgery now? And are there any new research in this field?
Of course, colorectal cancer, basically we need multi-modality treatment, we call it, which consists of surgery, chemotherapy. I mean, also newer things like targeted therapy. And also, I think the newest, in the research process is immunotherapy. I think Dr. Jennifer will be more familiar. I mean, in terms of surgery-wise, of course, there'll be advancement. Now we go from normal conventional open surgery. More and more surgeons are now doing keyhole or laparoscopic surgery and also robotic surgery. I mean, they're still in a lot of advancement, ongoing advancement and research.
Yeah, I do echo what Dr. Chong said.
Okay.
It's a very exciting era for cancer treatment now. So we are going more towards molecular precision medicine. So, but we still emphasize that the mainstay treatment for colorectal cancer, meaning the primary modality remains surgery. Surgery. So it's, but of course, for very locally advanced rectal cancer, sometimes we may need to downstage it so that we can get better outcomes. So that is where we call it neoadjuvant. So neoadjuvant is a treatment that is done before we do the definitive surgery. So we then may advocate the patient to go for radiotherapy and some low dose chemo. In terms of immunotherapy, I think a lot of cancer sites has already started seeing very good and tremendous result, being stage 4 lung cancer, stage 4 kidney cancer. So in the first line treatment for stage 4 cancer, immunotherapy has shown remarkable result. So we hope to see similar result in colorectal cancer. It's actually still in the research phase.
I see, I see. So other cancers, which is it very aggressive?
Pardon?
Compared to other cancers, how aggressive is it? If you compare to breast cancer or lung cancer, so is this type of colorectal cancer more aggressive?
I think again, it depends on the burden of disease, meaning at what stage the patient present with. So patient, as we see from the Malaysian data, there's still a significant number, almost 60% of Malaysian patients still present at stage 3 and stage 4, which means that they are presenting at the later stage and i.e. more aggressive presentation. So we hope that with improved screening method, more campaign awareness, we can shift the paradigm to a little bit to stage 1 and stage 2.
Okay, Dr. Chong, any last words for our viewers? Or Dr. Jennifer, anything that you would like to share more on this condition?
So, okay, from my practice, most of the patients who turns up when they presented late, is because they didn't go for proper checkup. Okay, very common. I have patients come to see me. The symptoms is rectal bleeding. They come with bleeding, but most of the time, they thought the bleeding is mainly due to hemorrhoids, and they just ignore it, or they just go to get some over-the-counter medication. So by the time they come back, because the symptom doesn't get better, it's most of the times it'll be at the late stage. So my advice is, for any especially in the older age group above 50, whenever you have bleeding, it's not normal. You need to go and seek a doctor's opinion and get it checked. Yeah.
What about you, Dr. Jennifer? Any last words?
So again, if you have any suspicious symptoms, or even sometimes just change in the bowel habit, sudden like constipation, and we know that sometimes the symptoms are quite, and they may have presented to their family physician, given some symptomatic medication. So the issue is, if that doesn't resolve the symptom well, then do seek professional advice again. Then when it comes to things like treatment, like chemo and all, we know that a lot of people are very fearful of the word chemo and radiotherapy.
Yes.
So we understand, and then that is why I think it's very important to understand the rationale or the logic of why the cancer doctor is offering it. Usually it is for maybe a stage 3 disease or stage 2, but have a open and frank discussion with the doctor and just share what your worry is, so that at least they can also make a combined decision when it comes to their treatment.
Yeah, I would like to add something.
Okay.
Is that okay?
Yeah, sure.
I agree with Dr. Jennifer. The other thing I encounter most is, a lot of patients, they are scared of surgery because, they thought colon cancer, when you have the surgery, you're going to carry a stoma permanently, which is not true, so that we need to educate the patient on that. And I do encounter patients after the surgery, even though they're stage 3, they refuse chemotherapy because when they heard the word chemo, they're, the first thing in the mind is, you lose your hair, you're getting very ill. So I always tell them, look, it's not as bad, you need to, That's why I said you better talk to the oncologist. They will tell you the good, advise you what are the next proper treatment. So like I said, for those who have confirmed or diagnosed cancer, don't be scared. Okay, seek treatment early, and the earlier you seek treatment, the better the result will be. Yep.
Right. Thank you, Dr. Jennifer and Dr. Chong. I have been speaking to Dr. Jennifer Leong, consultant clinical oncologist, and Dr. Chong Hoong, consultant colorectal surgeon, both from Sunway Medical Centre, speaking to us about colorectal cancer on BizTech Health and Wellness.